Hi, this is Junaid back again with Acute Ischemic Stroke 2019 Guideline Review. In this particular section, we're going to discuss mechanical thrombectomies and its indications and contraindications for stroke intervention. So let's start with the first and the foremost. Should you give concomitant IVtPA with mechanical thrombectomies? The answer is categorically yes. If you look at the level of evidence, it's A, and the class of recommendation is 1. Should you wait after giving TPA for sending patient to the mechanical thrombectomy? Absolutely not. You should not wait at all and send the patient, if it is eligible, for mechanical thrombectomy as soon as possible. No questions asked. Now, who is really eligible? And the eligibility criteria has been divided into 0 to 6 hours and then 6 to 16 and 16 to 24 technically. But let's just go from 0 to 6 and 6 to 24 hour windows as far as eligibility criteria is considered. Number one, as you can see, all patients with pre-stroke modified Rankin scale 0 to 1, occlusion in the ICA and M1, age above 18, and night stroke scale above 6, aspects above 6, and treatment can be started as soon as possible within 6 hours of the time window. The class of recommendation is 1, and look at the level of evidence here. The level of evidence is A. In those cases who might meet these criteria within 6 hours and night stroke scales less than equivalent or more than 6, aspects equivalent or more than 6, age 18, pre-modified Rankin scale of 1 or 0, no questions asked. Look at the level of evidence over here. Massive. The level of evidence right now is A and the class of recommendation is 1. So what about those slightly smaller vessels like M2, M3, where the NIH stroke scale because of aphasia can go up to 12, 18? Do you consider that? Apparently you can. The level of evidence in these situations is actually only B. And the class of recommendation is weaker, much weaker, actually 2B. But at the end of the day, in those patients you are thinking if they have significant disability and the mechanical thrombectomy is an option because you can see a large vessel occlusion, go ahead and consider sending these patients to mechanical thrombectomies. It is allowable to send those patients for even M2s and proximal M3s so that you can provide some care to these patients. Now let's come to some more of the weaker as far as recommendations are concerned. Now going back again from 0 to 6 hours, for those patients who have modified Rankin scale of more than 1, but don't have ICA or M1 occlusion, the recommendation is weaker. So basically 2 or less, but above 2, there's generally not a good recommendation to go ahead and do thrombectomies on those patients. So if the pre-modified Rankin scale, pre-morbid modified Rankin scale, the person coming in with significant disability, more than 1, the class of recommendation becomes weaker. And if you look at the level of evidence, is actually also B. So you have to always make sure that the pre-morbid disability is taken into consideration before even considering providing mechanical thrombectomy on those patients. On the same target, because we don't really have good data as far as other vessels are concerned, because all the big clinical trials, Mr. Clean, etc., were concentrated on ICA and M1 occlusions. What about the basilar? What about the ACA? What about the PCAs? All of these should definitely should be considered, but as you can see, the level of evidence starts to go to C and the class of recommendation becomes weaker. However, to be honest with you, in general, those people who are coming in within 0 to 6 hours with a large vessel occlusion, we are clearly offering them mechanical thrombectomies and of course supported by guidelines, however weaker. Now we come to 6 to 24 hours. In 6 to 24 hour window, the first are the two divisions. In between 6 to 16 hours, anyone who meets the criteria of either diffuse or dawn, and we're going to come to that in a minute, should be offered mechanical thrombectomy. Look at the level of evidence. A. Look at the class of recommendation. 1. Huge. So anyone who is coming with these symptoms within that time frame should be considered for mechanical thrombectomy. And those who are coming between 16 to 24 hours should meet the criteria of the dawn trial and not just the diffuse trial. So what is the dawn and the diffuse criteria of inclusion? So let's go with the diffuse first. 6 to 16. Life 18 to 90 years old, life expectancy of at least a year or 2 potentially. Life expectancy of at least 6 months. A modified Rankin scale of equivalent or less than 2. IC or M1 occlusion, and a mismatch. That's diffuse. Dawn, 6 to 24 hours. But the major difference is that you have to make sure that in these cases, NIH stroke scale is less than 10 as compared to diffuse 3, which was NIH stroke scale should be more than 10 as compared to diffuse, which was more than 6. So if those patients fit in these criteria, you should consider providing them with mechanical thrombectomies. Now, these are some technique level stuff that is important for general stroke physicians to understand as well, and not just interventionalists. So let's just go ahead and quickly go through them. However, technical details you can discuss with your neurointerventionalist. I'm not one. I'm a neurocritical care and a stroke physician and an epileptologist. So number one, use stent retrievers. So what they're trying to say is that stent retrievers have a higher level of evidence as compared to aspiration thrombectomies, etc. So you can still use it in the first pass. We're going to come to the next slide or so to see that, but stent retrievers definitely are the choice of technique as compared to mechanical thrombectomy is concerned. Technical goal is very clear to achieve 2B and 3. How should you do it? As soon as possible. The way you should do it is basically make sure that you evaluate rapidly as early as possible, so that patients who can be selected for mechanical thrombectomy are selected for mechanical thrombectomy and sent for mechanical thrombectomy. And as you can see, direct aspiration thrombectomies can be used for first pass, and that's important because some of these clots are very just went in from the heart and they are not stuck throughout the boundaries of the vessel, and if you do an aspiration they can come out. The reason some people do prefer aspiration is that the microclots that are going to go pass out and cause small distal infarcts are less often potentially and theoretically with aspiration technique. And in the first pass, if you try that, it's not unheard of to people to consider doing that first as compared to stent retriever. But generally speaking, nowadays, at least where I've been for the past 3 years, stent retrievers are used more often than anything else. And it is reasonable to select, anesthesia, whatever you like. If you want conscious sedation or if you want general anesthesia, either way you go ahead and consider doing that. There are people who are confused, aphasic, scared, and they are moving around on the table, and that can cause you to have, increased chances of vessel dissections, vessel puncture, etc. So it is better that the patients are technically slightly sedated, if not, but it is important to understand that to make sure that the blood pressure management is very, very hyperacute in those situations. You keep the blood pressure slightly on the higher side, 185 or so before the thrombectomy, and drop down as soon as possible if you need to, or even higher depending on where the clot is and how severe the symptoms are, etc. So blood pressure management becomes a key issue, and those people who are intubating in these patients need to be educated that the blood pressure is a key issue, and we need to make sure that the blood pressure requirements are achieving according to the patient's needs when the patient is being anesthetized. For example, I only use ketamine for putting these patients out when I'm intubating, especially in those cases when the procedure was started and then the patient started moving and all that. What happens is that you do not want to drop the blood pressure significantly. So I've done multiple intubations in the neuroangiography suite, and then we try not to be honest with you, because if you can go without it and then quickly get through this, that is actually better, because what we have seen is dropping blood pressure can cause you to have some side effects. So if it doesn't happen, we are always ready. We'll go ahead and intubate the patient within 5 to 10 minutes. And then in the meanwhile, the neurointerventionalist is busy doing all that. As a neurocritical care physician or as a stroke physician, I'm, making sure that the other stuff is going on. So we work as a team, and that is also very, very important. Using of a proximal balloon guide catheter and a proximal occluder is important to decrease the risk of having small punctate infarcts. Again, I'm not too familiar with this technique. You can ask the neurointerventionalist. It is recommended moderately as far as guidelines are concerned. And tandem occlusions, patients come with ICA or even a little bit lower into the carotids with an MCA. And should you do tandem occlusions? Absolutely, you should go ahead and do that. Some people do pass first, decrease M1. Some people do carotid, and then either way, whatever you decide, some people do stenting here and then go ahead and open that up. However you need to do it, tandem occlusions are a go, and you should go ahead and do that. It is according to the guidelines. Using some of these IVGP2, 3A inhibitors while you're doing these stent retrievers is uncertain. We don't know what the data is. You might have to use them again in acute stenting situations, especially with carotids, while you have to go, especially in tandem occlusions. The idea is that, it is a weaker recommendation, but if you have to do it, go ahead and do it. And then secondly, if you have to use IATPA in these situations, to soften the clot, to make sure that the patient actually the stent retriever is not able to do it, then go ahead and use our intra-arterial TPA, and that is again a weaker recommendation. Always, as I said, the blood pressure management is the key in these patients, especially before, during, and after the procedure. And some of these patients, the high risk of bleeding can be attributed to increased blood pressures, and making sure that these blood pressures remain below the targets of at least less than 180 after successful thrombectomy, and during and before the preparations is less than 185, as if you're going to give TPA. Clearly you want to remove the clot and make sure that there's not a rush of blood going, then causing a significant amount of reperfusion injury. So those are the things that you always have to make sure and consider when you're doing these procedures. We have made special boxes of blood pressure boxes. We call it antihypertensive medication boxes, and we have it spread out in the neuro ICU, in the ER, in the neuroangiography suite, and they have pre-filled syringes of labetalol, hydralazine, and then nicardipine drip you can mix it up quickly so that you don't delay anything. And all those boxes are available and spread out in wherever those stroke patients might be. And the idea is to always making sure that the blood pressure of the patient remains in the ideal range for these kind of interventions, both TPA and mechanical thrombectomy. Now, one of the key things that we have to understand is that intra-arterial IA therapy is not preferred over stent retrievers. Let me repeat that. If stent retrievers are preferred over IA therapy. But look at the level of evidence here. The level of evidence is C, but the class of recommendation is 1, because the evidence is so overwhelming for mechanical thrombectomies that the IA therapy no longer holds ground or to mechanical thrombectomy. So therefore, IA therapies, to be honest with you, one of the times that we generally, or I recommend personally when I'm talking to my neurointerventionalist, is mid-basilar strokes, which the chances of that because of a plaque rupture are higher. And then when you are softening the clot, then you go to do the stent retriever. I feel like there have been a better success rate, because then those patients sometimes do come at a later window, and sometimes the rapid assessment is not that clear because people think that these are seizures or having respiratory distress and all that. So making sure that you use IA therapy appropriately, it is important as well, but that is not the first choice. The first choice still remains to be the stent retrievers. I'm very grateful for your time. Thank you so much. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.